بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. Again, I'm Muhammad Al-Sunaid. I'm the Vice President of the Society of Nephrology and Transplantation. At the beginning, I would like to welcome all of you to this scientific activity on the second day of the second Critical Care Nephrology and Hemodialysis Conference. I hope all of you are enjoying the scientific material of this conference so far. Before we conclude the second day of this conference, today we have the Industrial Symposium sponsored by SBMACO, and the speaker in this Industrial Symposium is well-known Professor Sandeep Mitra. He's from the University of Manchester, Professor of Medicine and Nephrology, UK, and he's going to talk about an interesting topic, advancing anemia management in CKD. Professor Mitra, his mic is yours now.
Good evening, everyone, and Mr. Chairperson and the organizers, thank you very much for inviting me to this very innovative conference in Saudi. And although I can't meet you all in person, I'm delighted to be presenting to you on our webinar far away in Manchester. So good evening from Manchester to all of you. So the topic that has been allocated to me is really an interesting one in the context of shaping nephrology for the future. And the reason I say this is because anemia management has been the mainstay of our practice in advanced kidney disease patients, one that we've been used to over the years with several agents in practice. However, it is perhaps time to review how we practice the management of anemia, other ways that things can be done better in an effort to improve the outcomes. So in that context, I was asked to cover this topic with a view to perhaps talking about some of the more newer agents in clinical practice. Let me start by saying, I think I can't move my slide. Oops. So the concept of anemia has existed in CKD, but as you can see, it's a complex process. It is about kidneys that are aging, failing, diseased, inflamed, that gradually wear and scar out such that the circulating erythropoietin from the kidney is gradually diminished or becomes dysfunctional, and thereby leading to immature cells and inability to produce red blood cell precursors laden with hemoglobin, and therefore resulting in anemia. However, as you can see, this whole process of erythropoiesis is carefully controlled by many other external factors, one of them being inflammation or infection other than kidney disease, or deficiency of nutrients such as iron, vitamin B12, or presence of other chronic diseases. And of course, the presence of bleeding disorders, including hemoglobinopathies such as thalassemia. And it's important to understand that it's not just a very simple deficiency of erythropoietin. And I say this because patients with severe kidney failure can still mount a response with erythropoietin to severe anemia. And therefore, it has been difficult to prove direct correlation between erythropoietin levels in the blood and anemia. And hence, it is not recommended that in investigating anemia of CKD, we need to necessarily measure erythropoietin levels. But really the mantra here is that of balancing treatment in an effort to improve outcomes, but also minimize adverse side effects associated with the various agents that are used to treat anemia. We know that we use ESAs and iron in the management. However, despite our extensive experience with these agents, many questions remain regarding the optimal and the safe therapeutic endpoints. Let me just look at iron deficiency first. For example, in carrying out testing iron deficiency, generally we recommend every 3 months measurements of iron stores or iron status. And in this regard, ferritin and TSATs or transferrin saturation has remained the most widely used markers even today. Transferrin saturation and serum ferritin measurements are used in standard algorithms to direct management of anemia. But there are other markers that could be used if the test is available and with some caveats. For example, hypochromic red cells or the percentage of cells that are hypochromic needs to be less than 6% to have adequate iron stores. If it's more than 6%, that suggests iron deficiency. But only if these blood samples can be processed within 6 hours. And this facility may not be available in all laboratories. Retic hemoglobin count is another one. Again, that's something relatively easy to measure on the blood sample that has been sent, but requires a degree of interaction with the laboratory team to see whether you can acquire some of these results. And there's been some landmark trials in use of iron in dialysis patients. And the key one to focus on is perhaps a pivotal trial published in the New England Journal of Medicine. A UK trial was looking at the difference in outcomes between use of a very proactive high dose IV iron using iron sucrose 400 milligrams per month, aiming for these parameters, against a more reactive, more minimalist IV iron stores, and to see whether these are actually result in different outcomes. And the reason why this trial was important, because there's been an equipoise or uncertainty about how much iron is safe for our patients. As you can see, the primary endpoint was actually strong and hard outcome measures. This was mainly done on incident hemodialysis patients. Here is a proactive iron group, and you can see the two groups were well separated in terms of the dose of iron they received. And interestingly, the outcome measures suggest that both these approaches, high dose iron particularly, which is in the blue line, is quite safe and has as much safety and efficacy as in low dose iron, but also it provides a cardioprotective effect. As you can see on a superiority value, the high dose iron was clinically and statistically significant in providing cardioprotection. And of course, there was a significant reduction in ESA usage with high dose iron. And this was a pivotal trial, very important. And important to say that there was no difference in infection rates between the two groups. This is landmark because this has triggered much more liberal use of iron in our patients, such that they can be optimized. The high dose iron strategy is not only safe, but reduces ESA and dosing perhaps, and also easier to manage anemia, possibly with cardiovascular protective effect. It can't be generalized to all. For example, this was an incident hemodialysis patients as opposed to prevalent group. And of course, high dose iron has been in use in some parts of the world, particularly in the US. And we don't know what is the highest level of ferritin that is relatively safe for our patients. So some questions remain unanswered, but this really paves the way for more liberal use of iron in our patients. And of course, then comes ESAs, the cornerstone of anemia management, which involves the administration of erythropoietin stimulating agents to minimize transfusions and improve quality of life. A drug that has been well known and has really been game-changing for improving outcomes and quality of life in our patients with advanced kidney failure. A glycoprotein molecule that weighs around 30 kilodaltons. As you can see, the structure is described here and has gone through a very checkered history of development. That is one of the uniques of developments in science in trying to make it easily accessible and approved for use in renal-related anemia. However, many questions remain unanswered. For example, what is the target hemoglobin with ESAs? There was this equipoise to should we normalize hemoglobin in our patients? And again, some trials over the past 10 years or so has led to some real change in our decision-making and thinking of how we use ESAs. This is normalized in the hematocrit study, the COIR and the TREAT study, looking at dialysis patients with heart failure, or those are not on dialysis with a hemoglobin of less than 11, and dialysis and diabetics being treated with darbepoetin. And these trials were trying to look at difference in outcomes between two groups treated to a normalized hemoglobin close to 13 or above 12 versus much more modest rise in hemoglobin to between 10 and 11.5, as you can see. Interestingly, the trial showed that on all-cause mortality and stroke in this last trial, there was an increased hazard ratio, higher incidence of mortality and stroke and other cardiovascular events in the group that maintained or achieved the higher hemoglobin. This really has again changed our thinking and changed the algorithms and the practice guidelines that have emerged since then in how we should be targeting the hemoglobin. You can see here that therefore the targets now is to not necessarily normalize hemoglobins in our patients on ESAs, but to maintain a hemoglobin between 10 to 12 grams per TL or 100 to 120 grams per liter in adults. And an important statement here in the NICE document says that it's important to maintain a hemoglobin level within this aspirational range. And how do you do that? By reacting to that hemoglobin level, looking at trends and responding to when the values are almost 5 grams per liter on either side. So for example, if it's 115 here on the upper end, you need to start scaling back the EPO. Or when it's close to 105, you may need to start increasing the EPO slightly. So look at the trend and react within those margins. Goal here being to stay within those prescribed targets as rigidly and as carefully as that can be done. The other important thing to bear in mind is, although we talk about ESAs and iron, they're not necessarily all equal. There are several types of agents available for us to use, but not all ESAs are created equal for a variety of reasons. They're structurally different and they're pharmacokinetically different. Availability might differ between countries. Here, there's a study published only this year, pooled the analysis of 4 cohorts of non-dialysis CKD patients in Italian renal clinics, 400 patients in a short-acting ESA versus long-acting ESA group. And they were looking at differences in outcomes. And the endpoint that they were looking at is an end-stage kidney disease or death. And you can see that what they're reporting is that those who are on the short-acting ESA dose, there was a 2-fold higher risk of the primary endpoint of ESRD or death compared to the long-acting group. And this wasn't visible in the long-acting cohort. Importantly, this difference between the long-acting and the short-acting ESA was more pronounced when the doses that were used were on the higher end. So therefore, increases in doses of ESAs seem to be much more favorable in terms of outcomes when we are using longer-acting ones versus the shorter-acting ESAs. An important study, I think, that makes us think of how we should change our practice. So a more fundamental question is, why do we use ESAs? Okay, so if it's to improve mortality, that's probably misconstrued or misinterpreted, because as I showed you, the studies show that the targets of hemoglobin can be important in determining outcomes, and normalizing hemoglobin is not necessarily beneficial for our patients. And this meta-analysis review through the Cochrane group looked at all hard outcome measures with all the EPO trials that have been done. And we're reporting that the ESAs really offer benefit in our patients with anemia to largely improve quality of life, physical function, and to lower the need for transfusions. These are the 3 principal indications of benefit of ESAs in our patients. There's a lack of data on comparative differences between different ESA formulations. And they seem to have a similar hard outcome measures. But therefore, the preferences for different agents does depend on availability, but also on dosing frequency, which might be considered to individualize care, one that is best meets the needs of the individuals. And I'll come to that in a minute. But this is a very thorough meta-analysis published a few years ago, showing that the benefit of ESA is really, so therefore, it's important to look for symptoms in patients, quality of life measures, and of course, blood transfusion requirements, and whether the patients are staying within the target to decide how you prescribe ESAs and of course, adjust the dose. So there are different types of ESA. I've talked about the short-acting ESA and the longer-acting ones that are available. Most of them have been in routine clinical practice. However, the one that is most unique in its molecular structure is the longest-acting ESA, also known as SERA, or the methoxypolyethylene glycol epoetin beta erythropoietin. It's also known as SERA, which stands for continuous erythropoietin receptor activator. And I can show you why that is significantly different from the others. Look at this graph. this shows you that the half-life of the ESA is significantly higher, almost threefold compared to all the other ESAs. And therefore, pharmacokinetically, fundamentally, it's a different molecule, both for intravenous and subcutaneous use. The question is, does it offer any benefit to our patients in having an ESA that has such a longer half-life and therefore lower dosing schedule and frequency? You can see that the chemical modification leads to a much more higher molecular weight of 60 kilodaltons in the molecule itself. And this form of pegylation is not unique to renal medicine. There are other drugs, for example, interferon and other agents that have been done, but it's a fairly very advanced chemical technique to increase the efficacy and the half-life of molecules. So the first question is, of course, being such a long-acting ESA, is sera in CKD safe and efficacious? And this trial is a summative trial looking at a 4-year follow-up of 1,600 patients in all modalities, pre-dialysis, hemodialysis, and PD, where patients have been switched from epoetin on this side and darbepoetin, this group, to sera. And you can see that the hemoglobin levels following the switch have been very steady in all the groups, pretty much maintained within that target that we've been talking about, 10 to 12 or 110 to 120, depending on which units you use. So very reassuring set of data with very low adverse events, saying that, okay, although the molecular structure is unique and very long acting, it seems to be quite safe and gives us a desired goal of maintaining hemoglobin within a certain range of values. That's quite reassuring. Then you can look at once monthly dosing. Because of the long half-life, it now offers us an opportunity to just dose a patient once a month. This is in patients on dialysis. Pooled data again from phase 3 trials, 2,000 patients where they were switched to monthly sera across 13 countries, as you can see here. Again, very reassuring, stable hemoglobin targets achieved, predominantly between 11 to 11.5, not exceeding 12, and well above 10. Again, very reassuring set of results. An interesting finding from this, these pooled analysis reported by Locatelli and his group, is that when they looked at two groups of patients separated by the BNP level, the high BNP levels, presumably with compromised cardiac function, showed a significantly higher incidence of ESA resistance and inflammatory markers, suggesting that comorbidities can play a role in how well your patients respond to these ESAs and must be taken into consideration when you're dosing them. So that's an interesting set of findings. So continuing on dialysis, now patients here in this trial done by the PROTOS study investigators, published in the CJSN in 2007, showed that again, very satisfactory levels of hemoglobin achieved in patients who are switched from epoetin weekly to once or twice monthly sera. As you can see, the once a month dose seems to be as good as twice a month dose, again suggesting the value of this molecule that is much more longer acting. The dosing changes from epoetin was 8,000 to 60, and you can see 100 and 180 micrograms for every 2-week dosing. And that was a study design. Again, a very reassuring set of results that it does do what it's supposed to in terms of its molecular structure and pharmacokinetics. This is switched from darbepoetin, weekly darbepoetin to sera. As you can see, again, very satisfactory hemoglobin levels, well within this sort of target that were achieved. And the switch is from 60 to 180 microgram every 2 weeks. Moving on to non-dialysis patients. Now, this is chronic kidney disease not on dialysis, use of sera. And in comparison to darbepoetin, I can see two groups of patients, one's left on darbepoetin and the other switch to sera twice a month, fortnightly. These are the two curves. Again, every 2-week correction of the anemia is very satisfactory. Interestingly, this curve is that of this is darbepoetin and this is sera. You can see in the correction phase, the rise of hemoglobin is much less steeper in the sera group than in the darbepoetin group, which is again slightly favorable because you know that some of the complications of rapid correction of hematocrit is considered to be the thrombogenicity of a high viscosity, high hematocrit, and therefore gradual correction is recommended. And this seems to be slightly favorable, although not statistically significantly different in the two groups. This works similarly, but in the early phase, better slope of correction. This is now use of it in the non-dialysis patients, but using subcutaneous dosing once a month. So this is where this may be game-changing for your patient pathways. You can see that use of sera once a month to correct anemia again and maintain them in CKD patients not on dialysis. This is the two targets, 10 and 12, very well within the range. What I found interesting here as well, again, that slope from the sera group in the correction phase much more gentle than the very steep slope seen in darbepoetin. Statistically not significantly different, but favorable signals. And here you can see that there's an interesting graph in this paper published in the NDT showing that at least one hemoglobin value over 12 during the first 8 weeks, which is an overshoot essentially in the first correction phase, was significantly higher in the darbepoetin group compared to the sera group. Again, one that is favorable in terms of using such a longer acting molecule. How to switch? Okay, logistically, what do we need to do? General recommendation is to start, if it's once a month dosing, 1.2 microgram per kilograms. If it's fortnightly, half of that, 0.6 micrograms per kilograms for not on dialysis. And of course, you can use both subcutaneous injections, obviously, in the not on dialysis patients. And in this phase, it's 0.6 microgram. The important thing to bear in mind is as you adjust the dosing in terms of the maintenance phase, the recommendation is to adjust the dose by a 25% increase or decrease as a general rule of thumb. And that way you can get to the target level without causing overshoot, etc. And you get a much smoother maintenance of hemoglobin within your aspirational range. So a rough calculation of how to correct anemia when you're starting patients on sera. Obviously, these are patients currently not on ESA. They're just going on it for the first time, assuming they're iron replete as well. These are patients who are already on ESA. If you wanted to switch them to the longer acting molecule, how do you go about it? You can see these are the dosing recommendations. How do you equivalent doses essentially this is Mircera compared to epoetin compared to darbepoetin. These are just sort of good algorithms and nomograms to have in your offices and dialysis units to cause the conversion. And you can see that this is the recommended dosing. And if you look at the real world experience of what doses these patients end up with when you've switched to the longer acting version, and this includes non-dialysis and all dialysis patients, these are the typical doses you will need depending on patients' requirement at baseline. And the dose generally will vary between 50 to 200 once a month. Of course, subcut and IV, depending on which type of patients you're treating them with. Again, an easy reminder here is to change the doses on a monthly basis by approximately 50%, either an increase or decrease to stay within your recommended range. A quick word about resistance, because that was an issue a decade or perhaps 15 years ago. We realized that some of the problems was, we could actually get a lot of ESA resistance, and that was quite well studied at the time. The clinical teaching obviously is that look for these factors. Is there underlying chronic blood loss, infection, repeated hospitalizations, repeated blood loss from phlebotomy sometimes, poor dialysis clearances, high PTH, possible aluminum overload if the water quality may not have been assured in the practicing areas, and of course deficiency in vitamins. These are the sort of first differentials that need to be considered. But when these have been addressed, if the need for ESAs to stay within the hemoglobin range is not achieved, despite the use of nearly 300 units per kilo per week, or 450 for the subcut and the IV dosage, and of course 1.5 microgram per kilogram per week for darbepoetin. These are generally recommended thresholds beyond which you need to sort of suspect ESA resistance, provided these factors have been addressed. Of course, if you are suspecting pure aplasia, a very rare complication with EPO, but has been reported in the past, you need to look for antibodies. And the important thing is to do a more urgent referral to hematology teams to consider bone marrow, etc., and further testing. Of course, if there's aluminum toxicity being suspected, desferoxamine would be an appropriate intervention. But at this stage, when there is severe degree of resistance, all other factors have been ruled out. Hematology opinion is going to be essential. Well, post-COVID, how does it change what we do with anemia management? Well, here's an example of what might change. This is what happened during COVID was obviously the phlebotomy service in hospitals were significantly reduced at the height of the pandemic, and patients could not readily come into hospital for blood tests. So these patients on ESAs needed dose adjusting based on hemoglobin levels. And what happened was we have utilized in 2 centers reported in the CKJ Clinical Kidney Journal recently a home monitoring kit where hemoglobin was being measured by the patient at home, which is connected through a telemedicine telemetric device to report back to the center along with blood pressure to be able to adjust the ESA dosage. Again, distant and telemedicine at play with the use of novel technology and internet capabilities. So adaptation to the times, a lot of innovation may be required to make the pathways more seamless, safer, and more effective. Cost-wise, not a lot of data other than the fact that, of course, reduction in blood transfusion, improving quality of life and physical function has a wider societal benefit and the individual benefit in terms of functionality of our patients who are burdened with dialysis and advanced CKD. And ESAs have been game-changing, life-changing experience for many of our patients who have been able to go on to do much more than they would have otherwise been physically able to do since ESA has been introduced. I'm sure you have your own stories to tell of your own patients who you've looked after. But this study in the Journal of Medical Economics published last year shows that actually, looking at data from different continents, having ESA versus no ESA starting somebody on ESA does reduce costs per patient per month cost of, there's a reduction in the direct healthcare cost amongst treated patients in the 6 months following initiation. And finally, if these patients are on it already, maintaining the hemoglobin for longer periods above 11 around 11 would actually lead to reduction in cost. So leaving them anemic for longer periods could lead to higher costs, of course. So there is some cost effectiveness here in terms of lowering costs and health-related quality of life benefits. I want to summarize what I've said. What are the take-home messages? Okay, so the first, aim to have an individualized patient approach. That's the difference in how we used to practice before and now. We have to individualize what we do, take the patient consideration into account, look for the lowest efficacious dose, alleviate symptoms for patients, so therefore need to ask patients about different symptoms, and aim to stay within that target. Of course, reduce the need for blood transfusion. These are the clinical benefits you want to achieve through prescription of ESA. Of course, long actings are here to stay and may be preferred for a variety of reasons that I've already stated to you, both clinical and logistical advantages. In this regard, the longest acting ESA is the Sera, unique molecule, longest dosing interval because of its kinetics and half-life, which, as data would suggest, leads to quite sustained, tight, and stable hemoglobin. Combining such efficacy with high dosing interval puts some of these long-acting ESAs, particularly Sera, into a very advantageous position for us to use both in dialysis units and as well as in the non-dialysis pathways. You expect to improve quality of life and some cost benefit, but there's need for innovation in care in the anemia management pathways, particularly in the post-COVID era. Thank you very much for listening.
Thank you, Dr. Sandeep, for the excellent presentation and keeping with the time. I received a couple of questions, so maybe I will share it with you. The first question from Dr. Khalid Khan is asking, what's your approach to the patient who are resistant to erythropoietin?
Sure. So I think if I can go back to my resistance slide. So I think these are the clinical factors to rule out. So that's number one. The obvious ones are to look for why they're not responding, investigation for chronic blood loss, of course, particularly in older patients, um, looking at whether the patients have had a lot of hospitalization or infective episodes. Missed doses of ESA is quite not that uncommon as you would imagine. So look for the ESA tracker, prescription charts on how much dosing has been missed. Um, and that's again, if you are on a longer acting ESAs, I think the effect of missed dose might be less relevant than shorter acting ESAs. Of course, look at dialysis. I find this a very important factor in resistance to for the hyperparathyroidism. Good PTH control is essential to improve the responsiveness to ESA. Water quality is of course important, and of course deficiency in vitamins. I've talked about iron supplementation. Aggressive iron replenishment is required for the ESAs to be most effective. And you'll find that your ESA doses might be less required, lower dosing may be required with good iron repletion. Use the pivotal study, change your iron protocols if you're using more modest regimes to go for more aggressive replenishment of iron. And then if those factors have been addressed and you're still meeting with very, very high need for ESA, then of course look for antibodies and other bone marrow hematologic investigations. One of the things I did mention is chronic inflammation or infection is one key factor we tend to ignore, can lead to much need for a much higher ESAs. And of course comorbidities. I showed you some data where high BNP levels have been associated with a very high ESA resistance index. So optimal management of comorbidities would be essential. Some of it which be managed irreversible, others could be unmodifiable.
Mhm. Okay, fair enough. The second question we received from Dr. Iman Nuruddin. Her question saying, do we know if patients who are erythropoietin hyporesponsive behave different on SERA?
Good question. I think between the different types of ESAs, there is no data to suggest that the responsiveness might be different, because the responsiveness are the factors rather than the ESA types itself. So the answer is no. However, one big factor to bear in mind is that one of the reasons for poor response to anemia is the administration and the scheduling and the prescribing of it. Every time they get hospitalized, ESA doses may be missed, or sometimes they may be missed because of dialysis scheduling misses, or forget to get it. So those interruptions or disruptions to administration of ESA can be reduced significantly by longer acting ESAs. And by doing that, you are ensuring that these molecules are within the system at a much more stable level than, it's like an antihypertensive drug, the best analogy. So short-acting antihypertensives are as good as perhaps the longer-acting ones. But why do we use the longer-acting ones? Because the trough and the peaks that we get with shorter-acting antihypertensives leads to much larger peaks of blood pressures, swings of blood pressure. And therefore, we like one that has much more 24-hour profile, longer-acting blood pressure medications throughout a 24-hour period. So with longer-acting ESAs, sorry, particularly the longest dosing interval, you're likely to maintain better hemoglobin stability and plateau and less disruption and fluctuations in hemoglobin level.
Okay, maybe we'll take the last question from Dr. Abdurrahman. He's asking, do we take a consideration of blood pressure in hemoglobin target?
Sorry, can you repeat that question for me once more?
Yeah, sorry. Dr. Abdurrahman asking, do we take a consideration of blood pressure level in hemoglobin target?
A brilliant question again, a very good question. I wish I had dwelled a bit on that again, but it's such an important point in that one of the reasons for interruption of ESA or missing ESA doses in our patients is because of fluctuation in blood pressure. As we know, our dialysis patients, pre-dialysis patients have very difficult to control blood pressure, and the nurses or if the patient, the doctors would often resist administering ESAs because of those blood pressure fluctuations. Now, of course, we use a threshold beyond which ESAs are not recommended in high blood pressure setting, but those need to be very wide settings of blood pressure, not when the blood pressure move from 150 to 160. So then there's need for individualization. Of course, some of the blood pressure is volume driven, not necessarily. So I would suggest that in order to try and obviate the effect of blood pressure and ESA leading to disruption of ESA prescribing, that we resort to some of the more longer acting ESAs, such that you're not stopping and switching, and that becomes less of a determinant. But generally, you need to have in your own protocol a blood pressure cutoff at which the patient doesn't get the ESA dosing. And this is only relevant because you're giving the ESA doses once, twice, or 3 times a week. When you give it once a month, it becomes less of an issue. You can concentrate on the management of the blood pressure itself, rather than trying to think of how to swap and change ESA versus blood pressure. It becomes a nightmare for nurses, for doctors, and for patients. So it's another advantage of using something that is once a month, because then you don't have to worry about the interaction. You can focus on the blood pressure management and let the hemoglobin stay within the aspirational range. Does that answer your question?
Yes, very clear. I think there is, because of the time, I think we have to stop here. Again, thank you, Dr. Sandeep, for your excellent presentation. And also, I would like to thank our colleague in Slimaco company for sponsoring this industrial symposium. And also, I would like to thank all the audience and participants who really actively participate in this conference. And we come to the conclusion of the second day of conference, and I hope everybody is enjoying the conference so far. Tomorrow we'll meet the third day and last day of our conference at 4:30. So I hope to see you all tomorrow at 4:30. Thank you very much, everybody, and good night.
Good night, everyone. Thank you.